All right, are you able to see that?
Yeah, we can see that.
Okay, perfect. So my name is Catherine Collada, and I'm one of the third-year pediatric residents. And I will be talking today about a new type of interdisciplinary case conference that addresses bias and inequities in healthcare, and it's called Health Equity Rounds. So the objectives of today's talk are to discuss the rationale for discussing bias in our healthcare system, to outline the development, format, and topics covered in Health Equity Rounds, to talk about the initial impact and then next steps for broadening the impact of Health Equity Rounds. To give a little bit of background, within the past decade or more, health disparities based on identity, so race, religion, socioeconomic status, sexual orientation, and other aspects of identity have been well noted to have different health disparities. And a lot of work has been done to figure out why these health disparities exist and also what can be done to mitigate them. So taking a look at one topic that I'm particularly passionate about, the racial disparity in infant mortality. We can see here that infants born to non-Hispanic Black people are much higher than those born to non-Hispanic white or Hispanic white birthing parents. And this is not just a national or even statewide phenomenon, it's local. So these charts here show that we also see a much higher infant mortality rate among our Black infants compared to white infants in the Denver and Adams and Arapahoe County areas within the past decade or so. And we know that this is not isolated to the racial disparity in infant mortality either. So Black children suffer from asthma at 2 times the rate of their white counterparts. We know that providers spend less time in direct patient care with their non-English speaking families, and that patients of minority backgrounds or minoritized backgrounds report less satisfaction with their health care. We also know that transgender and non-binary youth have higher rates of attempted death by suicide than their cisgendered peers, and that those who perceive more discrimination from their healthcare providers are less likely to seek care or proceed with physician recommendations. And a lot of research has shown that implicit bias and systemic racism contribute to these health inequities. And that is above and beyond what can be accounted for by socioeconomic status, education, some other social determinants of health alone. Implicit bias can be defined as learned prejudices based on one's own lived experiences that are unconsciously exercised and lead to the evaluation of a person or situation, oftentimes without intention or without knowing it. And systemic racism refers to legislation, policies, institutional factors that perpetuate inequities in society. And we have these in healthcare as well as in society in general. As healthcare providers, we have an incredible privilege of being able to be with our patients at some of the most difficult, vulnerable, profound, and sometimes even mundane moments of their lives. And knowing that we are all coming to healthcare with our own lived experiences and implicit biases, and that we work in a system in which systemic inequities lead some people to be able to reach their full health potential more easily than others. We were struck by the need to talk about bias in healthcare and how it impacts our patients on a day-to-day basis and based on their own clinical experiences. So in speaking with one of my program directors, Dr. Carol Okada, and one of my mentors, Dr. Brandy Freeman, we came up with the idea to create a forum for discussing bias in healthcare and looking at how aspects of identity influence the care that patients receive as well as their health outcomes. With their incredible support, we were able to move forward with creating the initial steps to make health equity rounds. So we envisioned health equity rounds to be a case-based discussion that was a hybrid in-person and Zoom conference for our pediatric residency program in the section of pediatric hospital medicine at Children's Hospital Colorado and Denver Health. We also have expanded to include other sections throughout the series, and a big focus of our goals was to include interdisciplinary care team members from both clinical and non-clinical roles to make sure that we had good representation and understanding of the full patient scenario, because each team member brings a different perspective. Unlike a traditional case conference, we focus less on the medical decision-making or clinical aspects of the case, like you might in a traditional M&M conference, but instead shifted the focus to use the case as a launching point for discussion and exploration of bias in the care that we provide. I have the learning objectives of health equity rounds listed here, and to highlight them briefly, we hope to discuss ways in which individual and collective biases may have influenced the care of a patient or their family, to discuss the historical context related to health disparities or health inequities, because when we talk about health inequities, it's really important to understand foundational policies and then also practices and procedures that perpetuate these inequities moving forward. And finally, to collaborate with one another to brainstorm policy-based changes and personal changes that can contribute to health justice within our community. This slide shows potential topics to address in health equity rounds. And the really cool thing that we found with the cases that we've used so far is that oftentimes our patients represent multiple identities, and this provides the opportunity to talk about intersectionality within each case that we've used. In order to evaluate the initial impact and also figure out how to improve health equity rounds, we did use a pre-post survey, both at the beginning of the conference and directly after the conference, to understand how people were able to define certain terms, their behaviors related to health equity practices, and then also any anticipated practice changes. And I'll go into this more in depth in a few slides. I wanted to highlight a couple of the cases that we used for our pilot series, just to give an idea of the types of things that we talked about. So the first case was about a 15-month-old from a Native American reservation who initially presented with a respiratory illness that required a prolonged hospitalization. And at one point in her stay, her mother had expressed that they felt like they were being treated differently because of the color of their skin. This allowed us the opportunity to talk about health equity, intergenerational trauma, and the history of Native nations in our country. The second case that we talked about was a 12-year-old who presented multiple times for care before ultimately being diagnosed with anti-NMDA receptor encephalitis. And we talked about English proficiency and language, the use of interpreters and anchoring bias, and helping to have the family understand the diagnosis and helping us as providers to better meet the needs of this family and also identify what may have led to a delay in diagnosis of her care. The third case that we had in our pilot series was a 7-year-old with autism spectrum disorder and a new diagnosis of leukemia, whose family left against medical advice prior to seeking treatment, ultimately found to be in order to practice a period of prayer that was really important for them. So we talked about spirituality and religion as well as neurodiversity, and we talked about how to build trust with our families and ultimately how to partner with providers in our community with cultural similarities to the patient in order to help get them the care that they need and provide a good outcome medically and in terms of building a relationship that is trustworthy within healthcare. To go over some initial results, I have here a list of roles that were represented in the health equity rounds. And so you can see we had many people from different disciplines and specialties. However, I will say we definitely had more residents and attending physicians, given that this was piloted within the pediatric residency program. In terms of our pre-post data, looking at knowledge of certain definitions and then perceived ability to identify health equity practices, we used a Likert scale and then combined the categories agree and strongly agree and looked at the change in proportional agreement before versus after health equity rounds. The results are indicated here. And as you can see, most people knew about health equity and could define implicit bias both before and after, but there was a statistically significant increase in those able to define the iceberg model of culture, as well as those able to identify institutional and systemic policies and practices that contributed to inequities in the workplace and possible practice changes that could help move towards health justice. We asked about frequency of behaviors related to discussing bias in the workplace for members who had been joining health equity rounds for the first time versus people who had attended the health equity rounds previously. Frequencies ranged from less than once a month to daily, and we combined the categories weekly, multiple times per week, and daily to show the change in people who practice these behaviors at least weekly. And as you can see, we had an increase in all categories of behavior with a statistically significant increase in the healthcare team as a whole discussing bias and health equity. In order to look at the overall impact or value of health equity rounds, you can see here that most respondents found that this activity was relevant to their practice, increased their professional competence, and thought it would contribute to improved patient care and patient outcomes. 88% of participants responded that they thought they would make changes to their practice based on health equity rounds. And these anticipated practice changes included checking one's own biases and listening to families more intentionally, improving communication both with patients and families, as well as with team members, and being really intentional in the language that we use to talk about our patients and families. It also, people reported trying to utilize resources such as their interdisciplinary care team members more effectively and reflect on their own actions. In terms of system-based change ideas, there was discussion about hiring providers who were culturally diverse and multilingual in order to provide better care for our patients. Removing terms from our EPIC diagnostic and order sets that are considered cultural appropriation in order to be more accurate and also more appropriate with the language that we use to document. To standardize documentation to include interpreter use, and also to modify timing of visits to allow for more time when interpreters are needed. And some of these changes have already been in the works, while others will require more time and systemic changes from leadership positions and how we structure our healthcare visits in general. In terms of future directions, our pediatric chief residents have been very gracious in taking on health equity rounds to be a consistent part of our noon conference series within the pediatric residency program. And then various sections throughout the Department of Pediatrics have decided to hold their own health equity rounds for their section. And we've had the idea of coming together annually or semi-annually in grand rounds to either discuss a sentinel case related to implicit bias and health equity, or to discuss key lesson learned from each section's individual health equity rounds. And then we've created a facilitator guide, so feel free to reach out if this is something of interest to you. And then just to conclude, Health Equity Rounds provides the opportunity to identify bias and barriers to health equity in our clinical care, to develop the tools to speak about bias in a professional setting, and identify opportunities for more just and equitable care. We demonstrated that it's a feasible and valued practice within the healthcare community and has the potential to impact personal and systemic changes. We do need more work in order to increase representation and then magnify the impact by creating this as a regular practice throughout our campus and throughout our healthcare system. I'd like to take a moment to acknowledge everyone listed on this slide, especially Dr. Brandy Freeman and Dr. Matt Guerreri, who are instrumental in the creation, implementation, and assessment of the initial impact of Health Equity Rounds. I want to thank you all for your time and then use the last couple minutes here for any questions that you may have.
Thanks for that presentation. What lessons learned would you say there are in terms of other people kind of thinking about disseminating something similar outside of Department of Pediatrics?
So I think the major lessons learned would be definitely to include people from various disciplines. So including our spiritual care team, our interpretation services, people from child life, nursing, and various members of the healthcare team was really helpful in understanding each patient's case, as well as general cultural factors, hospital resources, and just how we interact with our patients that we as providers might not see or fully have an idea of on our own. So I think that was one of the biggest things. And then also having a plan for sustainability to ensure that practices can carry on and this can become just a regular part of what we do and how we see the impact of this in our healthcare system. Any other questions?
Not a question, but more of an advertisement. So thanks, Catherine, for this beautiful presentation. We do actually have a Health Equity Rounds at Children's Hospital happening tomorrow at noon from 12 to 1 in person in the Aspen conference room in the first floor of the administrative pavilion at Children's, or on Zoom. And I put the link to the Zoom in the chat, as well as our Health Equity Rounds 4-part series conference flyer. And then the facilitator guide, all to be downloaded in the chat.
Thanks so much, Matt.
Thank you, everybody. It's nice to see everybody. And I just want to make sure, can everybody hear me okay? Excellent. Yep. Alrighty. Well, my name is Rudy Moravec. I am a physician assistant with the Division of Hospital Medicine. I am also one of our associate directors for our Advanced Practice Fellowship in Hospital Medicine. And the project that I've been continuing to work on with the Teaching Scholars Program is the use of simulated education for improving both knowledge and confidence in caring for the acutely decompensating patient who's hospitalized, with our specific population being our advanced practice providers who are enrolled in a postgraduate hospital medicine training fellowship. So just to give you all a little bit of background about what our fellowship is, it's 13 months and it is for both physician assistants as well as nurse practitioners, all who are seeking additional training in caring for the hospitalized patient. Most commonly, the fellows that we draw to our program are newly graduated, so just finished their physician assistant training or their nurse practitioner training. Our fellowship does have 2 cohorts a year, one cohort starting in March and one cohort starting in September. And in its current state with the project, our fellows have 2 opportunities to go through our simulation program, once within the first 2 weeks of starting fellowship. And then depending on the fellows' schedules, we bring them back. Our goal is around month 5, but it can be anywhere between months 4 to 6 for a second session. My apologies, there we go. Primary topics that we go through with these simulations are patient scenarios that really revolve around rapid response calls, or what used to be called METs, or medical emergency team calls in the hospital. And the primary patient scenarios revolve around respiratory failure, tachycardia, hypotension, hypertensive emergency, and stroke. And the way we have this program set up to collect data is for measuring confidence to see if we can improve a fellow's confidence in caring for these patients. We have a pre, post, and exit survey that measure self-perceived levels of confidence, which we'll go into a little bit more detail later in the presentation. And then in terms of trying to see if we are actually getting the information that we're aiming towards across to our fellows, and if they are actually retaining that information, there's a 24-question written assessment that I have put together. The fellows will complete the assessment initially before doing any simulation, and then they will complete the exact same assessment after they complete the second sessions of simulations. All responses are anonymous. Because we have such a small population, it was recommended by our Division of Hospital Medicine data team that fellows develop a unique identification number so that we can actually track our fellows' responses between the surveys and the test. And then all data is collected into REDCap for further analysis. And we'll go over the data that we have thus far at the end of towards the end of the presentation. Reason we're focusing on these topics is these are very common concerns that we get calls for by our bedside nurse colleagues. And the reality is the training on actually dealing with these issues, or how to approach these issues in acutely decompensating patient, is pretty limited. I went and reviewed the expectations for certification exam for both physician assistants and acute care nurse practitioners. I focused on acute care nurse practitioners because that's who we can only take applicants for to work at UC Health. And so for the physician assistants, they take their PANS exam, and 13% of the exam is cardiovascular questions, 10% is pulmonary questions, and 7% is for neurology. And while they do touch on these topics or expect providers to have some level of knowledge of these topics. For example, under cardiovascular, we do have hypotension. It does mention cardiogenic and septic shock, but does not refer to any other forms of shock. It does touch up on the different tachyarrhythmias that we'd expect to see on the hospital floor. And then it does have hypertensive emergency as an individual topic. For pulmonary, it does briefly touch up on the various topics, but not respiratory failure as a whole. And then neurology does have separate topics or separate expectations for stroke and intracranial hemorrhage. The expectations for nurse practitioners are a little bit different, reviewing the handbook that they have to prepare for their exam. And again, breakdown, cardiovascular, 15% of their exam, a separate section of multi-system, which is 14%, respiratory is 11%, and neurology is 8%. And again, in a lot of aspects, they do touch on some of the topics that we mentioned, but not really going into a lot of, not going into a whole ton of detail. Obviously, they need to know enough to pass their exam. But for anyone who does work clinically and at the bedside, it is prominent that learning how to take a test and answer questions on an exam is very different than applying the information to a patient in real time. And the reality is advanced practice providers can start working in hospital medicine immediately after they're done with their certification or licensure requirements. They don't need to do any type of a fellowship. And the level of supervision and guidance that a fellow may have will vary greatly depending on where a fellow may start working as soon as they're done. And they, depending on where they are, they will be expected to take care of the acutely decompensating hospitalized patient with a level of proficiency to keep patients safe. And so our goal with the Simulation Center is to provide a practice without risk environment for our fellows. Again, most of them are newly graduated and stepping into their provider roles, where they can actually see these types of scenarios, have an opportunity to think through and practice on these scenarios before they're going to be expected to take care of these patients in real time. And so this is the current program setup from a bird's eye view. Fellows are introduced to the Simulation Center. They see our goals and objectives and our expectations that we have from the program itself. They are provided with introduction and assigned pre-reading with articles that do focus on those primary topics that they see in the first session in order to help prime them for that first session. And then when they actually arrive for the first time in the Simulation Center, before they do anything, they take a pre-survey and they do that pre-test, that 24 question written assessment. And then we actually jump into the simulations themselves, and I'll break down how that works in the next couple of slides with a detailed debrief after each session. And then immediately after that first session, they take a post survey. And again, these surveys are really focusing on confidence intervals to see if our simulation experience is improving fellows' confidence taking care of these patients. For the second session, again, our goal is around 5 months to bring them back. Depending on the fellow schedule, it may be between 4 to 6 months. They jump right into the simulation. We have different topics that are slightly more complicated with different patient presentations. And it does have the same format in terms of how they're run, but then after the fellows are done with that second session, they will go back and retake that 24 question written assessment. It is the same assessment from the first session to the second session with our goal of tracking to see if there's any improvement in their scores. And then after all of this, they will take the exit survey, doing that final evaluation on measuring their confidence levels, taking care of these types of patients. So when this fellow comes to the Simulation Center, we break up the fellowship into 2 different groups. There's 5 to 6 fellows per cohort. And so typically 2 or 3 fellows will go in the morning, and then the other 2 or 3 fellows in the same cohort will go in the afternoon. And each fellow will go into the simulation and complete a simulation individually. However, in order to create a comprehensive learning environment, all simulations are broadcasted on a non-recorded screen where the other 2 fellows in that session can watch. They can see and hear in real time what's going on in the simulation. We provide a pad that shows the vital signs so that the colleagues can actually see the changes in the vital signs as the fellow is completing the simulation, going through different treatment options. And then after a simulation is complete, we bring all fellows together. And this is where we spend a lot of our time, is doing a detailed debrief using the PEARLS model, where there's a combination of both self-reflection on how the fellow feel the simulation overall went, what they feel are the big takeaways. But then we do a much more detailed and in-depth review of the primary learning points that we're hoping the fellows would be taken away from the session. So if the fellows have a case where the patient has septic shock, going over the primary learning points for starters of, well, what do you do in this situation? What are the steps you should be taking? How do you approach these patients? But then also a detailed conversation about shock and all its different subcategories in general. And so even though only one fellow will actually do a specific simulation, all fellows will be able to see, observe, and get the main takeaway points and the main learning points.
Information for this coming year.
Our
So I feel like
goals
we
from
didn't
this
really get a lot
is
of
really to
information
try
from
to
school
improve
this year.
patient care and
So I had to
patient
email them to make
outcomes
sure I have their names
for
correct
these
for
providers, these fellows, future patients. We want to aim in helping improve the understanding of the pathophysiology of these primary situations or scenarios that we have built for our fellows, and then how to actually clinically approach these situations in terms of creating a differential diagnosis, what are the initial steps for workup, and what is the initial treatment for these decompensating patients for these specific scenarios. And we achieve these goals really based off of the prior slide through going through these detailed simulations with detailed debriefing sessions. We try to help prime our learners with the pre-reading before the simulation itself so that they can get more out of their learning. The written assessment the questions are based around the topics at hand. So all of it we try to keep tied together with these 5 topics: hypotension, respiratory failure, tachycardia, stroke, and hypertensive emergency. So with the data that we've collected thus far, and we've been collecting this data through REDCap, working with the Division of Hospital Medicine data team. For starters, we'll look at the surveys, and all surveys are based on a 4-point Likert scale with the focus on a fellow's perceived confidence. And decided to focus on this because when I first started creating this program, doing a literature search, there's not really any data in terms of where there can be good data collection for our population in particular. We have a very niche population that we work with our postgraduate fellows. And so one thing that is important when you're a medical provider and taking care of these patients is you just need to have some level of confidence on how to approach these patients so that you don't freeze and don't do anything. You just need to know what you need to get started in order to evaluate and stabilize these patients. So on the pre, post, and exit survey, the questions that we have this 4-point Likert scale on, measuring the confidence and taking care of the acutely ill or hospitalized patient, actually taking care of the critically ill or decompensating patient, and then having a firm understanding of the pathophysiology to consider for these decompensating hospitalized patients. And then we do ask an additional question on the post and exit survey is we want to make sure that fellows feel that they're actually getting benefit from doing this program. So we do ask them if they feel that their time in the simulation center is helping improve their medical practice. And what we have thus far for our first question of taking care of a hospitalized or acutely ill patient, we do see an overall trend in fellows feeling more confident in taking care of the hospitalized patient. And we see this actually, this seems to be a common theme as you will see in the next few slides. The biggest improvement that we see in levels of confidence is between the pre and post survey. So again, that's a survey they take before and after that first session. What we don't see as robust of confident responses on the exit survey, which is when they come back between months 4 to 6 and redo this and do the survey after they've completed the second simulation session. In terms of actually taking care of the actively decompensating patient, again, the most robust improvements in levels of perceived confidence we see is on that pre and post survey. While there is an improvement on that exit survey 4 to 6 months later, we're just not seeing as strong of responses in terms of how confident our fellows are feeling. And then in terms of understanding the pathophysiology, the exact same trend. Great improvement between the pre and post survey. We still see that improvement on the exit survey, but just not as strong or robust. And then the overall sense that we're getting is that fellows are showing a favorable view of the simulation center when it comes to taking care of patients who are experiencing these types of clinical scenarios and having that opportunity to practice working through these types of situations with that detailed debrief to help them go on and continue caring for patients who are hospitalized. And then as for our 24-question written assessment, we do see it's a very mild improvement between the pre-test and post-test. But the most improvement we see is that improvement in the minimum score with an improvement from 12 to 16 points or answers correctly, but not much of an improvement in the maximum score. So it's very, very mild changes that we're actually seeing on the component of knowledge acquisition that we're hoping to assess. So what we've gathered from this data thus far, and again, this is all very preliminary data. We have a very small patient population, and we've just started collecting this data fairly recently. So we still need to collect a little more data to see if these trends do continue, but fellows are seeing the simulation center as a helpful component for learning their medical practice. It does appear to improve confidence, but that confidence does not appear to carry over after an extended period of time, or at least the same level of confidence doesn't. And while there was a small improvement in the written assessment, it's really not enough data to determine if this is even significant at all. Really big points to consider, especially for this written assessment. It's not a standardized assessment. I could not find a standardized assessment for this type of population and in this for these types of scenarios. But it's also hard to say, is the improvement that we're seeing on these test scores, whether it's significant or not, is it due to what we're doing in the simulation center, or is it by the fact that these fellows have been participating in this fellowship for the last 5 months? At this point, it's too early to tell. So any questions?
Thanks for that presentation, Rudy. I think, it's such an important topic, right? How do we really help people, on board and get confident within, their area of domain, particularly, I think, for, physician assistants and nurse practitioners, as you know, where you can sort of move from specialty to specialty, right? So I think figuring out how to leverage the simulation center is a great way to kind of move that forward. What's kind of version 2.0? What do you imagine sort of doing next along this line of work?
Grand scheme. If the hardest part about expanding this has been my personal availability and being able to get fellows into the simulation center more, while we could bring them in further, we do have more opportunities to bring them in later into their fellowship, but where are we going to get the most bang for our buck? I had tried to see if we could utilize the Oxford VR simulation that they have over at Cape. However, conversations have kind of stalled, and the issue with that is typically funding. I have been able to get interest from more of our advanced practice providers in the Division of Hospital Medicine. If I can get more people on board, having a much more standardized assessment where a fellow can come in individually. We have a more complicated scenario. We have multiple providers watching and multiple assessors watching, and we basically have a standardized checklist about what we'd expect our fellows to go through in these types of situations. And then as the fellow goes through it, we can give them direct feedback afterward about, okay, this is where you checked off correctly here, but when you initially went in and assessed the fellow, you really should have had a quicker time frame in terms of doing your primary assessment, circulation, airway, and breathing to determine, does this patient actually do you need to get a little bit more aggressive, or do you have a little bit more time to think about things? And so I would love to incorporate something like that into it. And again, the challenge on that has been, I'm just one person being able to do this, and I need to be able to get a little bit more assistance. Again, have people who have expressed interest in being more involved, but in terms of actually getting to those next steps have proven challenging. Another aspect that could be good is What other types of areas would people who are leadership, who have leadership positions and other fellowships similar to ours, where do they feel we could get more bang for our buck with this? Do they feel that focusing on the rapid responses and medical emergency team responses, do they feel that is a good utilization, or do they see other areas that they think simulation education could be beneficial? And so I had started in terms of gathering contacts and trying to set up interviews with leadership at other fellowships with a similar makeup to ours. But with time constraints, I just haven't been able to get to that yet.
Thanks so much, Rudy. Rebecca, you are up next.
I'm sorry, I'm having trouble hearing you.
Oh, sorry. I was just thanking you and letting Rebecca know that she's up next, and she can start sharing hers.
Riley, can you confirm that you can see my screen?
Yep, we can see it.
Perfect. Thank you so much, you guys. I'm Rebecca Beatty. I'm a hospitalist in Northern Colorado, and I am actually teaching medical students today. So I'm in the hospital with not the best internet, but I appreciate the chance to present virtually for you guys. So my medical education work currently is focused on building a new course for fourth-year medical students here in Fort Collins and also at Anschutz. So I'll start by giving a little bit of background on this project. So I think most people would agree that all physicians serve as leaders in some capacity, often starting quite early, whether it's the fourth-year med student leading the second-year med student, or the interns helping the medical students, or then the senior resident guiding the interns, on and on up the chain until we're talking about leading committees, leading departments, or acting as the chief medical officer of a whole hospital system. So undergraduate medical leadership curriculum up to this point is largely delivered to medical students in either mentoring type relationships, within the clinical team setting, or in student-led activities like volunteer work, teaching opportunities, or student-led interest groups. So the CU School of Medicine is heading into this new TREC curriculum that I know you guys are very familiar with. And one unique aspect of this curriculum is that we are building a required leadership curriculum that all students will get, and fourth-year students have the opportunity to do a focused course called a trail on leadership as well. And so this is a simplified representation of the TREC curriculum that shows where this focused trail will fall. Starts sort of middle of third year, going through middle of fourth year. And I've put an arrow here next to the leadership course I'm developing, this health systems and community leadership trail. So as I started thinking about the curricular content to include, I started with literature review, and literature currently focuses on student perceptions of their own current curriculum. There is one prior study that does include faculty perspectives, but there's no literature that I could find that actually solicits opinions from experienced physician leaders about what skills they needed to acquire to be effective as leaders in their roles. And so the purpose of this study was to find out from physician leaders what we should teach our medical students, and to help guide the content development of this new course through that process. So I performed semi-structured qualitative interviews where I spent 30 minutes with medical leaders, physician leaders, asking 11 questions about the skills required to be effective physician leaders. And I've included some of the examples below of the questions we talked about. So things like, what is the most important skill for a physician leader to possess, and how did you learn that skill? Or in your experience, is there a key leadership skill you see physicians struggle with? And particularly, I asked them about physicians that are early in their careers, where they see them struggle the most. And then how and when did you master leadership competency areas like business and finance, healthcare policy, or strategic planning? And so I conducted 8 interviews with a sample of physician leaders in the Northern Colorado region, including our chief medical officer and associate chief medical officer, and the chief and vice chief of staff of our two main hospitals, Poudre Valley Hospital and Medical Center of the Rockies, and then 2 retired prior chief medical officers for the region. The physicians were all MDs, and they had a variety of specialties that I've listed here, including internal medicine, pulmonary, cardiology, anesthesia, surgery, and OBGYN. And there were 5 men and 3 women that I interviewed for the study. I'm still sort of amazed at this outcome. It's almost like the answers had been rehearsed by the leaders before I talked to them, because these 4 different skills were mentioned by all 8 leaders without any sort of prompting or priming. All of them mentioned that emotional intelligence, leading crucial conversations, change management, and collaboration with non-physician leaders were the most important skills that made them successful as leaders in our medical system. And I thought that was interesting because when I look back at literature, again, mostly focused on medical student perspectives, there's a paper that reports that medical students perceive themselves to be somewhat or fully competent in communication and conflict resolution, which I think is interesting that this discord exists between people's perceptions of their own skills and then this observation from advanced, experienced physician leaders that more junior physicians going into leadership roles seem to struggle to master these skills. Similarly, 6 out of the 8 people that I interviewed said that the more technical aspects of leadership, including business planning, finances, budget management, and revenue cycle management, were best learned experientially as people got their first leadership roles. And in this paper that I'm referencing, medical students perceived that these are the skills they really think they need to learn in order to round out their current leadership curriculum. You know, specifically, this paper mentions that medical students want to learn coding and billing, writing proposals, managed care, and investment principles. I thought these were, there were a lot of great quotes from interviews, so I just picked 4 to highlight out of millions. But the CMO of our system said, doctors are leaders, whether it's in your clinic or in the entire health system. Physicians should be leading healthcare, but doctors often don't understand their leadership style and aren't well prepared for collaboration, especially with colleagues who aren't doctors. They set themselves up for failure if they don't know how to read the room. And then she also said this second quote, I see a lot of doctors who want to be leaders get their MBA. But when I'm hiring my team, it's much more about people skills than the ability to read the financial spreadsheet. And then 2 quotes from the chief of staffs up here in the northern region. You usually become a leader because you have certain knowledge, skills, and expertise. Then when you're in leadership, you realize it's a different thing. It's not about having the answers. It's about trying to remove barriers for others so that they can do the best they can do. Leaders look at resources and barriers and try to get barriers out of the way. It's more of a service than a position or job title. And most leadership problems have nothing to do with clinical medicine. It's how to engage, communicate, and work with teams. So I think this really highlights the idea that leadership is a service model based largely on communication, team building, leading difficult conversations, leading change within the system, and less about some of these technical skills. So in conclusions, what did we learn from these interviews? Discrepancies definitely exist between student perceptions of their own skills and observations made by experienced physicians of early leaders and early career physicians and where they struggle. And definitely we learned that in our longitudinal leadership curriculum at CU, the following 4 competencies should be stressed, which is emotional intelligence, leading crucial conversations, change management, and collaboration. The study certainly limited. It was a small, convenient sample here in the northern region in a single campus. And I performed the interviews and reviewed all the data myself and certainly have my own biases that are probably show up in my qualitative data review. So the next steps for us moving forward and where we're heading next is we're currently building out the full Health Systems and Community Leadership Trail course. A pilot will be offered this October just at Anschutz campus, and then the full course will start in January of 2024, so a little less than a year from now. And the next steps that we're focusing on are determining the best ways to teach these competencies and the best way to assess the students to see if they've mastered them. Any questions for me?
I think this is really important work. Thanks for sharing, Rebecca. There's a lot of interest in leadership development at all levels, right? From medical students to residents to physicians in practice, and also a lot of interest in what's been called health system science, right? So kind of teaching people how to really improve the way we deliver care and understanding, the insurance and all these different components. And it's really interesting to me, the things that were highlighted were more some of these people skills, right, related to emotional intelligence and these other aspects. So I think that the project is super valuable, and the lessons learned, I think, are very interesting. I'm wondering what you think would be the next steps with your data in order to have a scholarly publication come out of this effort.
Yeah, that's a great question. We're hoping to round out the development of the course and then actually be able to publish how we assess that the students have learned these competencies. So starting with the pilot and then in the full course. I think assessing whether someone is a good communicator is quite difficult, and I'm sure that that's a struggle for all educators. And so figuring out how to best assess whether students are, good communicators, good collaborators, can lead change management, that's challenging for us, and that's where we're heading. So I hope that the publication will include sort of some pre and post surveys about our students and whether we can really teach them those skills.
Hey, Rebecca, I think that was really interesting. Thanks for sharing with us. I was thinking a little bit along the lines of what Lottie was saying, but wondering about like what's realistic can you teach students in the amount of time you have for a course. And because there is a little bit of data about students not maybe knowing what they really need to do leadership, I wonder if this could be a place where looking at their attitudes before and after might be interesting, and also an important part of it, because you won't be able to obviously get to some of those complex skills in the amount of time you have in a course.
Yeah, I think that's a great idea, Suzanne. And I think part of the course will be pairing each student with a local leader. And my hope is that whether it's something we teach them directly in lecture or whether they observe with their local leader, is that they can see that a lot of what our leaders spend time doing is facilitating, making connections and communicating between teams. And so hopefully, whether directly or indirectly, they can see that in action and learn that that's the main piece of leadership from our local team.
I think you actually have data there, Rebecca, that's really worth thinking about in terms of from a scholarly angle. You've done these interviews, right? You could potentially round them out with doing some interviews of leaders on the Anschutz Medical Campus, and then partner with other people interested in, leadership development, so that you have more than one person reading the comments or reading the transcripts, so that you can have some rigor in your qualitative data analysis. But I put a name of a person in the chat, Natalie, who's a PhD over in the School of Public Health, very interested in leadership development, works in the Total Worker Health program that is in the School of Public Health. And, you have some data there that's probably worth taking to the next level, in addition to your day job of figuring out how to develop, implement, roll out, and evaluate the curriculum. But I'd push you a little bit to maybe think about the data that you have in hand, potentially adding a little bit to that, coding it with somebody else, and writing a publication about, what are the skills that medical students should be getting with respect to leadership from the eyes of CMOs and leaders in an academic medical center and in a community setting. I think it would be really value addable.
Thank you. I appreciate that. And thanks for making the connection for me.
I think we're a little ahead of time. Riley, should we go ahead and just move on to the next presenter?
Yeah, our next presenter is here. So if you want to get started, you are totally welcome to.
All right. Hello, everyone. My name is Anuja Riles. I am a pediatrician here in Northern Colorado, and I'm part of the Fort Collins branch campus. So before I get started, I just wanted to thank you, Riley, for being so flexible with the fact that I couldn't come down to Anschutz today, just given clinical duties and allowing me to pivot to a virtual presentation. So I know you've probably gotten a lot of emails. I just want to give you a shout out for your ability to help me out with that. And I will go ahead and start sharing. All right, can everybody see my screen okay? All right. So what I'm going to talk about today is the CU School of Medicine at CSU veterinary shadowing experience. And the goal for this was really to expand opportunities for interprofessional collaboration at our campus, given the resources that we have here. Again, my name is Anuja Riles, and my role at the Fort Collins branch of the CU School of Medicine is as the One Health and Health and Society lead at our campus. So I'm going to start you out with the current clinical silos that exist. So I'm just going to read this out to you. So at the entrance of the emergency room, there was a group of 3 scrub-laden doctors in training crowded around a bearded dragon. A heat lamp shone above them as they rolled in a Doppler machine to find his heartbeat. And the chief complaint in that situation is he is failing and isn't eating. Across town at the entrance of the emergency room, there was a group of 3 scrub-laden doctors in training crowded around an ill-appearing elderly man. The bright lights shone above them as they rolled in an ultrasound machine to do an echocardiogram. Chief complaint is the same. He is failing and isn't eating. So, you know, on the left side, we have the veterinary teaching hospital, part of CSU, and that's kind of where that situation is taking place. And at the right side, we have UC Health. And currently they operate completely separately, one for animals, one for people. And my goal is to try to shatter that. And out of that goal, we created the veterinary shadowing experience. So this was created in 2021. And this was a veterinary shadowing program for our first year medical students. It was part of the One Health elective, which I won't talk about in detail today, but it's an elective that we offer in the Plains year for students only at the Fort Collins branch campus. The veterinary shadowing experience portion of the One Health elective had a requirement to spend a minimum of 2 to 4 hours in the CSU veterinary teaching hospital urgent care. And I'm wondering if this will allow me to share this with you instead. Give me 1 second. Skipping the ad here, and then we'll start the show.
Okay. I think you'll need to switch your screen too.
You're right. All right. So meeting, start share. We're going to go to this video. All right. Can you guys see that now? Oh, I can't see you. Is that a yes? Is that a thumbs up?
That's a yes.
Okay, great. All right, go ahead.
Urgent care is all about treating unexpected problems for dogs, cats, and our exotic animals like birds, lizards, snakes. We want to make sure clients know that their animals are always getting the best care in here, and there are lots of people helping their animal. When we get to the urgent care room, we're going to do an exam on Mavis and make sure she's stable. Check your teeth. Good job, Mavis. Check your lymph nodes and your ears. You're being a brave little pug. If our tests show that an animal needs surgery, we call the owner right away and we discuss what surgical procedure is needed, as well as the cost of that surgical procedure, and make sure the clients are comfortable pursuing that choice. One of the benefits of CSU is we have a pharmacy on site, so we can send home any medications your pet might need during the same visit. The most important thing to know about urgent care is that pets are always receiving care, even if their stay in urgent care is quite long. Sometimes we get busy and we're seeing many pets all at one time, but pets are always cared for, and we try to update their owners as often and as quickly as possible when we have new information to share.
All right, let's go back to my other screen. Okay, we're back to the PowerPoint. Everyone see that okay? Great. So I want you to take that experience and now imagine our medical students in that space and what the opportunities might be from that. All right, so the learning objectives of our program were threefold. So the first was to recognize that collaboration between human and veterinary medical professionals can benefit healthcare for both humans and animals. Two, to recognize that humans and animals share the same environment and health is interdependent. And then thirdly, to practice eliciting a history of human-animal environment interactions. So in 2021 to 2022, we had 6 students that spend time shadowing Dr. Mandy Kavanaugh, who you just saw in the veterinary teaching hospital urgent care. And in the fall of 2022, we had 12 students that shadowed in that same space. And I think probably many of you know this already, but as a reminder of where these students are while they are shadowing. So it's in that first year where largely they're classroom-based didactics organized by organ systems. They do have some clinical preceptorship experiences, anatomy lab, histology, pathology, and then of course the health and society. And that's the context that they're bringing into the veterinary space. So after the students engaged in shadowing, we did a post-experience focus group. My goal was to collect preliminary data on student experiences and takeaways. So we were able to interview 3 students from the 2021 to 2022 cohort, and they participated in an hour-long post-experience focus group. We asked the students to reflect on what skills they learned, what opportunities they saw for collaboration based on their experiences, any impacts that they had on their approach to human healthcare after being in the veterinary medicine space, and then any patterns that they noticed in terms of the interdependency of human and animal health. There were 4 preliminary themes that emerged from this focus group, and I will go through every one of them individually. So the first really revolved around opportunities for learning from veterinary colleagues. And I don't think that's one that we often think about as something that our students or even us as practicing physicians are able to do. Secondly, interdisciplinary relationships and appreciation. So remembering last year, the Fort Collins branch was brand new. And so that interdisciplinary and opportunity to spend time with other students and other professionals was something we really wanted to commit to. The third one was very surprising to me. So it revolved around imposter syndrome and how they can increase confidence, even just by being in the veterinary medicine space. And then lastly, joint community engagement opportunities. So for the first, so opportunities for learning from veterinary colleagues. The students really talked about how their veterinary colleagues had a grasp on death, dying, and quality of life, and how to bring the human owners into that conversation. So they commented how first-year, veterinary students and residents had very comfortable interactions surrounding these topics, which was in contrast to what they felt that they could do or that their colleagues could do. Secondly, they talked about how veterinary students were able to approach nonverbal patients and really engage in secondhand history taking. So in the first year, there is some exposure to pediatrics if your preceptor is in that space. But otherwise, they don't really have a deep depth engagement in their docs curriculum related to nonverbal patients or how to take a history from someone else outside of the patient themselves, which obviously veterinary medicine colleagues have to do all the time. Thirdly, they talked about cost of care discussions and financial impact of health. And Dr. Mandy Kavanaugh talked about this a little bit in that, anytime they find that an animal patient needs something, before proceeding, they have this in-depth conversation about the financial implications of that. Again, something that our students are not a part of typically in any clinical interactions that they had. And so they really enjoyed being able to witness that aspect of medicine. Team collaboration and roles in patient care. And so again, the veterinary teaching hospital is like Anschutz in that it has veterinary students, residents, fellows, it has nursing care, it has OT, it has PT. And so being able to see a lot of those roles and see how that's done in a different clinical silo was something that they wanted to take away. They talked about the impact of human meds and food on animals and vice versa. So how can we be more aware of toxicities related to that? And then lastly, provider safety. So how to keep providers safe in the clinical space. So you can imagine in the veterinary space, they're worrying about bites, scratches, and infectious diseases like the plague, that they have to keep their providers safe. And what are the protocols that exist surrounding that? And what can we learn and what can we bring over to the human medicine space? A quote that I pulled out is something that I talked to the veterinarian I shadowed about while I was there, is the parallels between veterinary patients and then pediatric patients, especially those that are nonverbal yet. So again, just getting to the fact that we can really be very similar despite having different patient populations. The second theme is interdisciplinary relationships and appreciation. And so they really appreciated the opportunity to engage socially and educationally with veterinary students and residents. I think at our branch campus, it's a small class. And so even more is the need to provide those opportunities. And the students felt like that was a great opportunity for them to do that. They also came away with an appreciation for the training in veterinary medicine and what their colleagues in the vet med side learn when they learn it and how in-depthly they learn it. And so all of a sudden it created this value and understanding of the veterinary medicine space, which going forward in the need of collaboration is really important. They understood training models better in veterinary medicine. And then they found that they have colleagues in the veterinary medicine space that are also combating burnout, mental health challenges, and educational debt. And so instead of human medical students and trainees having to combat those in isolation, you could imagine an opportunity for us to collaborate with the veterinary medicine world to help find solutions for our students in those spaces. And then a quote related to this theme: I think for me, what was really educational was kind of what I was saying earlier on, appreciating everything that veterinary students and residents go through in their training. So that word appreciation really stood out to me. Thirdly, so combating imposter syndrome and increasing confidence. And this one really took me by surprise, but it was one that came up time and time again in our focus group. So our students described this idea that their preceptor, Dr. Mandy Kavanaugh, and their patients had no expectation of our students. They just assumed that they had no understanding of animal health. And it allowed the students to feel free to ask any question without having this fear of asking something that they should already know. And that then allowed them to be increasingly comfortable with being uncomfortable or not an expert, which is very different than the clinical space that our students traditionally are in, even if they're a first year with a preceptor or in their LIC and AI experiences, in which they feel like they have something to prove. They're supposed to come with some set of skills and knowledge, and they have to be able to demonstrate them. In the veterinary space, they were free of all of that. And it really allowed them to engage and to learn. And that to me was a really interesting just phenomenon. They also talked about, because it was animals and, for some of these students, this was during COVID. And so human owners weren't allowed to be a part of there. And so they were allowed to do repeated and lengthy physical exams on animals without being questioned, without anyone stopping them. So a cat, for example, has a very, very, very fast heart rate. And so one of the students talked about how it was really helpful because it was helpful for him to listen to murmurs in a patient with a very, very, very fast heart rate, as you know, as infants do have as well. And he took his time and he was able to do that over and over again until he was really able to hear that murmur. And so the opportunities for practicing physical exam skills on animals and how they can translate to the human medicine world. And then lastly, that fostering of a growth mindset, and that there is a lot of opportunity to grow. And it's not about knowing it all and having to be the expert in the clinical space, but just taking away things with you and having it sort of add to your breadth of knowledge as opposed to having to prove something. A quote related to that: when I shadowed the vet, I would ask any question basically. And it was like cool and reassuring for me to know I had good questions, you know? Like she was like, I would not expect you to know that. That's a good question. So I don't know. I guess it was kind of a confidence booster for me. And then the last theme is the students really talked about this desire, now that they had been in this veterinary space with other trainees and practicing veterinarians, of joint community engagement opportunities. And they sort of threw out all kinds of ideas. So blood drives for both people and animals at the same time, joint free clinics. And actually one of our health and society project actually has that as well. Opportunities for nutrition, exercise, dental, mental health, and vaccine fairs that include people and their animals. They talked about using pet health to promote human health, and so a lot of pet owners care more about their animals sometimes than maybe prioritizing their own health. And so how do we leverage and how can we work with our veterinary colleagues to do that? And then lastly, they talked about joint advocacy, and that could be on the Hill. That could be related to pandemics and preventing future pandemics. That could be related to climate change and other topics that are affecting our patients as well as animal patients. A quote related to that is, how can we use veterinary outreach events to also reach the human population as well? So for vaccine drives, can we also bring human vaccines and try to get humans vaccinated? Or even like if we're doing free checkups for animals, can we also do that for the patients as well? And this is kind of a last quote that I'll leave out there. So it says, I want to go back to the vet hospital to do that more. I don't know if you guys remember, but after I shadowed, I did not stop talking about it. Like I kept telling everyone, even people not involved in the shadowing experience class, like, you got to set this up. You got to go do this. And I think especially at that point in our exposure to medicine, it was just such an interesting and encouraging experience that I think everyone should have. So next steps for us. So a reciprocal shadowing program, and actually we are just beginning to start this. So I have veterinary residents in the ICU space that are coming to our NICU to be able to practice procedures, watch and learn about temperature control, IV access and nutrition in neonates, and see how they can translate that to the veterinary ICU space. But we also can imagine opportunities in the ED and geriatrics. So expanding the shadowing program, so it's not just one way, but the fact that we can learn from each other as well. I can also imagine doing this exercise at different points in training. And so, we've done this in the first year. It's very low stakes practice, watching communication styles, practicing working in a team. And then you can imagine in the third or fourth year, as students have more clinical experiences under their belts, they could learn about more specific topics. So opioids, infectious diseases, discussions surrounding preventative medicine for animals and humans together. So cardiovascular disease, diabetes. And then again, this practice of death and dying and our approach to that in human medicine, and how students can feel more comfortable in that space by learning from veterinary medicine colleagues. And then lastly, expanding on existing joint community engagement opportunities. And so as part of the One Health Club here, we started a new program that's called Walk with the Doc. And we have community members that are invited to this event, and they bring their pets, and we'll have a veterinary cardiologist walk with human cardiologists, and community members can ask questions about human cardiology, can ask questions about veterinary cardiology and their pets. And so approaching that organ system in a joint fashion with both veterinarians and human medicine physicians. And then lastly, this inclusive health collaborative that we've started in Fort Collins, in which we are jointly seeing humans as well, humans that are homeless and then their pets for free, and doing joint care with veterinary students and our medical students. And so expanding on that program as well. I just want to give a couple thank yous. So Dr. Mandy Kavanaugh, she was the veterinarian you saw in the video, and she's the veterinarian that helped us set up this program and allowed our students to shadow her. Dr. Ellen Astar, who conducted the focus group and was able to translate all of that into text for me and help me come up with this presentation. Dr. Christy Reimer, who's our assistant dean and has been very supportive of the project. And then lastly, the students that participated in both the shadowing experience as well as in the focus group. And I will stop my share there, and I would love to take any questions.
Thanks, Anuja. That's great. But I'm already a fan. Just the one time that I did this shadowing, going to the vet hospital, it is transformative. So I'll just say from personal experience, there's, even at any stage in your career, it's really fascinating, and we need to do more. One of the things that struck me, because I have another soapbox I get onto, is the idea that the students felt so safe asking any question, and probably the opportunity for deep learning was greater in a way in that space. And so that puts me back on my soapbox. Is in our core clinical year for medical students, it's in more sort of fuel for the fire that if we could eliminate grades, students could just focus on becoming the best clinicians they could be. And I also loved, I hadn't even thought about how long you could spend listening to a cat's heart, for instance. And so I think we should just probably bring cats into docs. So, all right, those are my thoughts, but thank you for sharing that really good work.
Thanks.
I think the potential for IPE, right, is really untapped. And you know, if you look at kind of the IPE literature in the med-ed research world, everybody thinks it's a good idea, but there's very little outcome data, actually. So, you know, kind of what you are trying to do with this pilot here is to think really thoughtfully about what is some of that outcome data, right? And since it's very explorative, using qualitative data analysis seems very appropriate. So it's a small cohort, right? It's a small group, but if you keep repeating it, you know, over 2 or 3 years, you'd have a pretty good sample size that you then could, you know, do some more rigorous qualitative data analysis around and, you know, get a med-ed scholarship publication out of, because it's not you know, it's really interesting. People usually think about like, well, we'll do IP with nursing or with PT, or you know, rather than we'll do IP, we'll do interprofessional education with veterinary students. The only thing I hope is that we don't see a spike in career regret, you know, because animals are so darn cute, right? And like kids are cute. I'm an adult internist, like adults, you know, sometimes they're cute, but you know, kids are cute and like animals are cute, right? So, but really interesting work. So congratulations on that. And I hope you'll continue to collect this data and build something out of it down the road.
Yeah, I appreciate you saying that. I think you're right. I think that's one of our largest weaknesses is the small sample size. And we do hope the program will continue, and we do hope to continue to evaluate it to better understand the validity of those themes that come out. So I'm looking at the time. So any other questions or? Well, thank you guys. I appreciate your time.
All right, well, if there's no more questions, our next presenter can get started.
That sounds lovely. Thank you. I'll go ahead and share our screen here. Just a second. This opportunity to present. Okay, perfect. I'll give us an opportunity to introduce ourselves. So we are excited you all are here. My name is Dr. Deepika Patel. I'm a clinical psychologist. And on the call, my colleague, Dr. Lindsay DeVries, is also a clinical psychologist. We are both assistant professors in the Department of Developmental Pediatrics in the Department of Pediatrics at the Children's Hospital and the university. And we are so excited to be here talking to you about a passion of ours. We've been, over the last few years, we've been working hard to build a concentration for our trainees in our program to engage in more culturally sensitive work. So we're here today to talk to you a little bit more about the power of Jedi. So first and foremost, why is this important work? Why do we care? We really live in a time in our society where diversity is becoming greater and greater and becoming the majority, right, of our culture and our society. And we see intersectionalities of different cultural representations. And as clinicians, we really need to be more mindful of factors related to justice, equity, diversity, and inclusion. There's a lot of research, current research, that shows that having culturally competent providers leads to more positive outcomes in patient care. It also helps minimize healthcare inequities. So it's really important that we're thinking about cultural aspects in the work that we do and being more culturally informed in our care. In a lot of our graduate school experiences, we receive a lot of different didactics. We gather knowledge through our coursework, through our skill building, clinical rotations and aspects. A lot of it is focused on didactic and coursework. And postdoc training is particularly a time where it's crucial for professional development, professional identity, and focusing on some of these skill sets. And what we've recognized, or what our research shows, is that there's a lack of true intentionality within these postgraduate and postdoctoral experiences, and that there's really this need for active approaches for application of skill in culturally diverse backgrounds, or people who have culturally diverse backgrounds. And so our program has been working hard in developmental pediatrics to improve the work and our support for DEI efforts. We have a lot of different intersectionalities and sections where we provide comprehensive cultural care. And my colleague, Dr. DeVries, and I have been working really hard to improve ways to help support our trainees to both recruit as well as to retain and to create really well-rounded students and trainees who can go off into the community and provide culturally informed and sensitive care to our community.
So our overall goal in creating this program was Dr. Patel and I thought hard about how could we bring some intentionality to DEI work within our training program, because as she mentioned, we often get a lot of didactics, but the piece that we have found oftentimes was missing was the actual application of those skills when it came to clinical practice. So what we came up with was, how could we create a training experience for postdoctoral fellows that would think about these concepts intentionally by the application of culturally informed care? And how could we increase the amount of conversations that we had within our section, as well as opportunities for trainees to really consider where their strengths and biases and weaknesses were, so that we could help support them during this last bit of their training as a psychologist. And so we have been working to develop this program and thinking about how we could increase this aspect within the work that we do.
As we shared, this project started quite some time ago now. It's been a few years, but this gives kind of an overview of what we've been working towards and how we've implemented the pilot program this last year. So we started by doing a review of the literature. We thought it'd be important to see what's out there, what's already being done in clinical training programs. Are there evidence-based practices in psychology training that are really incorporating the applicational aspects of DEI efforts? What's being done, and how can we kind of move from that? What we realized pretty quickly on was there's relatively little. There's absolutely, being done in clinical psychology across postdoctoral experiences in postgraduate work. So we spent a lot of time also reviewing the American Psychological Association psychology training programs, statements of diversity, and this led to the creation of our baseline competencies. We thought through specific training objectives, and we thought through this across different tiered levels or developmental stages of our trainees. So we have trainees who come through who are currently in their graduate schooling and process through their externship or clinical fieldwork placements all the way up until postgraduate work. And we wanted to think about really how do we support their training goals, especially for students who are starting earlier on and are retained throughout the process. So we developed lots of training objectives, different specific goals for our trainees to be able to have an experience within DEI efforts. As well as then we wanted to consult with and collaborate with our stakeholders in our community. We spent a lot of time talking with colleagues in our Department of Developmental Pediatrics, as well as across the section of psychology and specifically psychology training, to help us understand their efforts and their values or beliefs in DEI work and training and teaching. And we invited them to share feedback on our objectives and competencies. We, after some revision, of course, then decided to pilot our program. So we created the JEDI concentration, the Justice, Equity, Diversity, and Inclusion concentration, which was piloted for our postdoctoral fellows this last academic year and within this academic year.
It took us some time to decide what these areas of competency were going to be. And in addition to the steps that Dr. Patel mentioned, one of the other things that we wanted to be conscientious of is that we often retain a lot of our trainees, where people may come in for an externship where they're still in graduate school and they're getting this their first foray into clinical experience with us, but then maybe they apply and stay on for internship, or interns may decide to apply and stay on for a postdoc. And so we wanted to think really critically about how we could make these areas of competency fit for our trainees at different levels if they had already been with us before and had maybe gotten some of these experiences. And so what we decided to do is we landed in thinking about these areas of competency based on all of the information and the data that we had collected. And so we started to think about it across 5 different domains: didactic experiences, assessment and evaluation, intervention, which would be therapy and directly working with folks, families in a treatment model, advocacy and teaching, and then also research and scholarship. And so here is an excerpt of what our JEDI training plan looks like. So we took these competencies and we decided what that was going to be. And we actually structured it for those 3 different levels of trainees. And the reason for that, again, is we wanted to think about the folks that are retained in our program. So this is a little bit of a segment of assessment and evaluation, as well as intervention, and what the expectations would be for each level of training. And so again, our pilot was really just has been looking at postdocs. And so we have been sharing these competencies with our training committee as well as our postdoctoral fellows, and have been working closely with them to make sure that they are able to reach these goals throughout their training.
One of the rich aspects of our program in just developmental pediatrics is that we have several psychologists and faculty who have specialty expertise in intersectionalities of autism and neurodevelopmental differences with other components of racial and ethnic backgrounds or linguistical backgrounds or gender diversity. And so part of some of this experience is for our trainees to be able to go through clinical rotations with based in their training goals and with their supervisors across sections. But Dr. DeVries and I also thought a lot about how do we want to make sure we're including this experience and having the opportunity to reflect on trainees' experience and their work in JEDI efforts throughout the year. So we thought a lot about having a JEDI mentor, or a Yoda, if you will, right? A JEDI champion, a faculty in our department who would be able to provide more mentorship throughout the year to ensure that trainees were getting the experiences that they felt they needed to be more well-rounded in their work, ways to advocate for JEDI efforts across the work that they were doing. And so we thought really carefully about how we wanted to have JEDI mentors who could provide mentorship throughout the year. What we thought would be important is for the opportunity to have regular meetings or supervision or mentorship meetings to be able to reflect, shape, cultivate those DEI experiences. And we thought it'd be important for our Jedi mentors to have reflection in their work and lead by demonstration or by model. And so we wanted for our Jedi mentors to be lifelong learners, or to identify as wanting to continuously expand and support their lifelong learning and DEI initiatives, whether that's through participation in different case conferences or associations and conferences within the sections of DEI trainings, whether that be self-improvement activities and book clubs or journal clubs. We wanted them to be able to participate and engage in those types of activities to show by demonstration and model, as well as then be able to support the trainees in the levels of DEI efforts that we had.
And so the mentors for this initial pilot, which I think we forgot to say, we just started the pilot this fall, and I think October was our first meeting. And so Dr. Patel and I are our first Jedi mentors, and we've been meeting with our trainees quarterly. And one of the things that's really a strength in our program is that we have so many different psychologists and different clinics and patient populations that we see, that there's a lot of supervision that happens. So oftentimes our trainees have multiple supervisors that they're getting feedback from in different areas, whether that be through an assessment with early preschool age children, or doing clinical work in individual therapy, or seeing patients in a one-day clinic, for instance. And so we wanted to make sure that we were able to check in with these individuals on a quarterly basis and really separate that out from the clinical supervision that they were likely already receiving, sometimes from us, but sometimes most of the time from other colleagues of ours as well. And so the goal of these mentorship meetings was really to try to check in and think about where they were at in their goals, as well as prioritizing the intentionality of how we could help support and provide some I think well-rounded and closing the loop on some of the experiences that they had. So some of the things that we've heard before, for instance, is that while we have these diverse patient populations in diverse clinics, sometimes our trainees are getting towards the end of their time and are saying, you know, actually, I've never worked with an interpreter, or actually, I've never seen somebody who is gender diverse where there's been a question of autism. I wonder what that looks like. And so we really wanted to make sure that we were starting the training year from the get-go by starting out with some intentionality around goals, checking in around those goals, and planning so that we could support them as appropriate. And so we spend our time checking in, talking about these factors, and thinking about how to support individuals through this process. And so like we shared, we are still, new to doing this, and we're still in the midst of piloting this, but these are a couple of quotations that we've collected. The first one is from one of our postdoctoral fellows, and the second is from one of our training directors. And I'll just read the first one real quick. The Jedi track has supported my training goals of gaining targeted clinical experiences with individuals from diverse backgrounds. I feel motivated and encouraged to seek clinical opportunities that may have otherwise been outside of my comfort zone, in addition to initiating conversations about diversity, equity, and inclusion in professional spaces. And that really was our goal. So we were thrilled when we received this feedback from one of our trainees.
As we shared, right, our pilot is small this year. We're working really hard to expand and think about next steps. And we, have spent a lot of time in the first year learning and building the curriculum, our program and concentration, and this last academic year being able to implement the mentorship and receive feedback from our trainees, from our training directors, as Dr. DeVries mentioned, And so our next steps are really to build upon this. We want to expand, so that it's not only postdoctoral psychology fellows. We created goals and competencies across different developmental levels. So we would love to include all of our trainees in psychology within this model, as well as collaborate with our medical colleagues. We have several DBPs, developmental behavioral pediatricians in our department, some who were already stakeholders in the initial developments of the collaborations and processes when we developed the training program, who have shared lots of wonderful interest and positive feedback in wanting to replicate or make this kind of a parallel process in the work with their DBP fellows and trainees. As well as we work with the LEND program at the larger JFK Partners Foundation, and we've had a lot of collaboration efforts or discussion around how can we support other trainees in speech and language pathology or occupational therapy or self-advocates to kind of think about some of these JEDI concentration efforts. We also, given that our group is small, we'd love to collect some data to really see what is the impact of the work that we're doing. How can we gather some information pre and post from our trainees, as well as direct supervisors or training leaders, to help us think about quality improvement and help us think about ways we can obtain feedback and modify for new trainees or adapt for future trainees as they come through and as we think about helping them become well established in the work that they do.
And so you may be thinking, well, I'm not in developmental pediatrics, so what does this mean for me? And, you know, our take-home goal was really to think about how we could bring, again, some intentionality to thinking about diversity, equity, inclusion in clinical practice, regardless of where that might be for you. And so we have noticed in our time doing this, that not only do we have more of these conversations with our trainees, we're also having more of them with faculty. And we've noticed a bit of a domino effect where, you know, just anecdotally, there have been conversations about, you know, I wonder if this would still apply to a family who just immigrated to this country, or I'm wondering if we need to think about the signage and whether or not that's accessible for everybody that comes through our clinic. And so some of the things that you can do if you're not in developmental pediatrics, or you're thinking about how do I support my trainees and other faculty to really, you know, hone in on this intentionality piece, is to start to think about ways that are small within your clinical practice where you can start to have these conversations. One of the things that we've started to do within developmental pediatrics across the board when we take on a new trainee is cultural shares, where we have a brief conversation at the beginning of a supervisory relationship about our own cultural background, and we model for the trainee what that might look like and encourage them to share as much or as little as they would like to as well, and talk about how that might impact our clinical care and what we're going to do to kind of stay accountable and think about our challenges, our strengths, and some of our lived experiences and how that might impact the patients that we see, the research that we conduct, and the teaching that we do. We also, some of the other things that we've done that might be applicable for your area of program is thinking about signage or materials, accessibility, visual aids, literacy levels. And then that has also trickled down into thinking about the groups that are maybe missing from the table when we conduct our research or when we're doing our teaching. How are we talking about people that are not in the room? How are we including people in those conversations? How are we elevating the voices that need to be elevated? And how do we adapt our practices, that some of which have been going on for quite some time, to support more diversity within all of those areas? And then lastly, thinking about the recruitment and retention of trainees, faculty, and staff that are from historically underrepresented backgrounds. And so thinking about, you know, how do we weigh our hiring decisions, or how do we incorporate questions into interview about people's views of diversity, equity, and inclusion, and think about the impact that that has on clinical care and what we value as a section, and how do we elevate that? And so I encourage you to think about some of those things and how you might incorporate that into your training or into your teaching or into your research as well.
And we just want to share our appreciation for you all to be here today and hearing our conversation. We'd love to spend the last few minutes just hearing questions or thoughts and reflections you all have, or work that you might be doing in your own sections in clinical practice or in research. And our contact information is here as well if you'd like to reach out to us after today.
Well, thank you very much for that presentation. It sort of brings up this possibility again, like we talked about earlier, about, interprofessional education as well, right? We're thinking about this really important topic of DEI education, health equity education, making sure everybody understands social determinants of health. And, but we do that in all these isolated ways, right? And it seems that postdocs in clinical fields like OT, PT, speech therapy, clinical psychology, need to have a lot of the same competencies as our residents, right? And they're somewhat similar in age, and also could be a way to build community. And, I think as you sort of continue this work, figuring out how to disseminate this effort, across different specialty areas, and then figuring out where are there opportunities potentially to partner with things that are going on in GME, so that we're not all recreating the wheel in silos, right? And I see, Brandy on here and Dr. Freeman's, the departmental diversity leader in children's, and thinking about, across the field at Anschutz Medical Center and at Denver Health and all the places where our learners go. There's a really enormous opportunity here to think about how to partner and expand and learn from this. So thank you for sharing today.
Thank you. There are really some great ways to collaborate across sections and interdisciplinary work. And we oftentimes connect with Dr. Freeman and have heard about neurology, and I think in neuropsychology doing some good collaboration and Jedi work as well. So we're hoping to kind of expand on those efforts as well. I think there's some great ways for that connection.
Great. Well, thank you very much. We're at time, and I have to run to the TSP graduation. So thank you to everybody who presented today, and I'm really excited to see this work move forward. Take care now.